So today we are talking about the reality of managing pulmonary embolism in ER and in ICU, and how it contrasts with what we often read in textbooks. So textbooks may present pulmonary embolism as a straightforward sudden onset of shortness of breath, chest pain, tachy, and the go-to treatment being anticoagulation, thrombolysis, or even surgery in severe cases. But in practice, diagnosing pulmonary embolism isn't always a very clear-cut uh, treatment. Patient doesn't always present with classic symptoms, and their clinical signs can often be misleading. For example, you might have a patient with chest pain, but it could be from heart attack, anxiety, or even PE. Tachycardia, maybe that could be from infection, anxiety, or pulmonary embolism. So the first solution here is improving the clinical suspicion. Don't rely on textbook symptoms alone and consider all possibilities. In the ER, we usually start with a clinical evaluation and use tools like D-dimer testing and CT pulmonary angiography to perform our suspicions. But these comes with their own challenges. If the D-dimer is elevated, it can be for other reasons: pregnancy, post surgical case, infections, malignancies. So we do D dimer only when the Wells criteria is less than 2. That means when there is low probability, then do a D dimer. Okay, and CT pulmonary angiography is contraindicated in patients who are having chronic kidney disease because we use an IV contrast. So patients who are having chronic kidney conditions, in that we can do a VQ mismatch. So if the D dimer is elevated for other reasons, the patient can be unstable also. So we cannot always wait for imaging. This is where early anticoagulation can be a life saving. Even before full confirmation, you can use an anticoagulant, especially when you suspect pulmonary embolism in high risk patients, obesity, post surgical conditions, long bone fractures. Patient was sedentary and was bedridden for a few days or months, right, in all those conditions. So we often have to take a balanced approach, starting treatment based on clinical suspicions, so then confirming with an imaging when the patient is stable enough. This is in emergency department. Now in ICU, things are more complicated because patients with pulmonary embolism usually come with complications in ICU department. By the time we see the patients, they often have complications like right ventricular failure or hypoxia. So the solution here is to intervene quickly with hemodynamic support, fluids, vasopressors, while simultaneously we're confirming the diagnosis as well. So the point of care is echocardiography. This can help identify the right heart strain and guide us towards pulmonary embolism being diagnosed faster. This is in ICU. So when it comes to massive pulmonary embolism with right ventricular failure, thrombosis is often the go-to treatment, but it's not always the first choice because it has a risk of bleeding, especially in patients with recent surgeries or those that are at high risk of hemorrhage, right? So the solution here is to individualize the care. We make decisions based on patients' risk factors, sometimes opting for thrombolysis, sometimes for embolectomy if thrombolysis is not suitable. And for those patients who don't respond to thrombolysis, ECMO. ECMO may be necessary, but ECMO offers a last ditch effort to stabilize patient with severe pulmonary embolism and shock. But it's very challenging decision. We need to consider factors like patient's overall prognosis and the risks and the benefits such as invasive intervention. So ultimately, the reality of pulmonary embolism management is about adapting to the situation. It's not about following a textbook path by using clinical judgment, early intervention, and flexible treatment plans. Whether you are in an ER or an ICU, you have to work with what you have uh, in your hand. Make decisions in the face of uncertainty and adjust as the patient's conditions evolves. So the unpredictability is what makes pulmonary embolism such a high stake critical decision making process. But by staying vigilant and adaptable, we can navigate these challenges more effectively. So, in the end, managing pulmonary embolism is not about memorizing textbook cases or following a rigid path. Like, okay, we did a chest x ray, it came out to be normal. ECG, we might expect having an S1Q3T3, and then we will do a Wells criteria. And if it is less than 2, okay, it's a low probability, go for D dimer. If it is more than 6, we can do a CT angiography, or we can do a VQ mismatch, right? It's about staying adaptable and using your clinical judgment to guide your decisions. The challenges we face in ER and ICU are unpredictable, but with the right approach, we make a significant difference in our patient's life. Always remember that medicine is not just about protocols, it's about understanding the nuances of each individual case and being ready to act with both knowledge and empathy. Stay sharp, stay flexible, and keep learning.